Welcome all for the today's class. So today we continue with our endocrinology module, and today's topic for the discussion is hypothalamic and pituitary hormones. Okay, so basically from our basic MBBS knowledge, we know that there is a hypothalamus, which is the master gland, and from there we get the hormones. These are regulatory hormones such as CRF, TRH, THRH, etc. These are releasing hormones which will act on the anterior pituitary, and anterior pituitary will then release the tropic hormones such as ACTH, TSH, LH, FSH, etc. And these hormones will act on the target hormones such as target organs such as adrenal cortex, thyroid, gonads, etc. And these target organs will then produce the further hormones like cortisol, thyroxine, estrogen, etc. And we have for regulation, we have short loop and long loop mechanism like from hypothalamus, these regulatory hormones which will act on the anterior pituitary to secrete the tropic hormone. The levels of these tropic hormones will act at the hypothalamus and will give the negative feedback. That is the short loop mechanism. Or if they are reduced, they will give the stimulatory effect. Okay, so this is called as a short loop mechanism. And the target organs, okay, the target organ hormones will act at the hypothalamus to give either stimulatory or inhibitory response. That is called as a long loop mechanism. Okay, so if these levels are increased, they will give the negative feedback. If these levels are less, they will give the stimulatory response. Okay, so this is the our basic knowledge. So basically, it's a sort of three-tier hormonal hierarchy. The hypothalamus is the master regulator, the pituitary is the messenger, and the target organs are the executors. And all of this is tightly controlled by the feedback loop. Okay, so what are these hormones basically? So we get the hormones from the hypothalamus. These are hypothalamic neuropeptides, and there are hypothalamic releasing and inhibiting hormones. So first we will discuss about the hypothalamic hormones, in which we have hypothalamic neuropeptides, that is vasopressin, ADH. Okay, and second is oxytocin. Okay, so basically what we call it, this vasopressin and oxytocin, these are the hormones coming from the posterior pituitary. They are released from the posterior pituitary, but they are produced, these are neuropeptides produced by the hypothalamus, and from there they via neurons they go to the posterior pituitary where they are stored and then they are released. Okay, so ADH and oxytocin are the hypothalamic neuropeptides. And another type of hormones coming from the hypothalamus is a hypothalamic releasing and inhibitory factors. Okay, so they control the anterior pituitary via portal circulation. So these are the releasing and inhibitory factors which will control the pituitary action. Okay, now let us see one by one. So first we'll discuss about the hypothalamic neuropeptides, that is ADH and the oxytocin. Okay, so basically these are the hormones which are produced mainly in the supraoptic and paraventricular nuclei of the hypothalamus. The supraoptic nucleus is concerned mainly with the ADH. Okay, so it is mainly the vasopressin or the ADH is related to the supraoptic nucleus, while paraventricular nucleus is mainly the oxytocin. Okay, so it is synthesized as a precursor polypeptide, then it is transported to the posterior pituitary, and then it is released by the exocytosis from the posterior pituitary. Okay, so in short, ADH and oxytocin are the hypothalamic neuropeptides synthesized in the hypothalamic nuclei but stored and released from the posterior pituitary. Okay, so this concept you understand. Okay, the next out of these two hormones, we will discuss first the antidiuretic hormone, that is ADH, also called as vasopressin. Okay, so the other name for the vasopressin is lysine vasopressin, LVP. Okay, where does it act? It acts on the distal convoluted tubule. Please note this the site of action because it can be a SBA. Okay, so this vasopressin will act on the distal convoluted tubule in the kidney, and the function is the water reabsorption. So it causes the water reabsorption and it decreases the urine output. Okay, so how does it act? It will bind with the receptor and it will activate the adenylate cyclase. So cyclic MP level will be increased, then the protein kinase activation will be there, and in the microtubule there will be certain changes and there will be water reabsorption finally. So this ADH is responsible for water reabsorption. Okay, now how it is regulated? So when there is an increase in the plasma osmolality, ADH levels will increase. If there is a decrease in osmolality, the plasma ADH levels will be reduced. Okay, so this is how the these levels of ADH are controlled. So it is the plasma osmolality. So it is a directly proportional. Increase plasma osmolality, increase secretion. Then it will cause water reabsorption. Then the osmolality will be maintained. If there is a decrease osmolality, there will be decrease ADH. So reduced water absorption. Okay. And again, the osmolality will be maintained. Okay. Now, what are the clinical conditions affecting the ADH? There may be ADH deficiency, which is clinically what we call it as a diabetes insipidus. So it is a large volume dilute urine what we get, and there is a hypernatremia and decreased ECF volume. So remember ADH deficiency or diabetes insipidus, you will get hypernatremia. Okay, so in the causes of hypernatremia, please keep in mind endocrinological cause as a diabetes insipidus, and there is a decrease in extracellular fluid volume. Then even there is a excess ADH, that is called as SIADH, syndrome of inappropriate ADH secretion. Okay, so excess ADH will lead to SIADH, and the cause is ectopic secretion, mainly the tumors. Okay, and clinical feature is a hyponatremia. Okay, so when there is a excess ADH secretion, there will be excess water reabsorption, and patient will have the dilutional hyponatremia. Then hypotonic ECF expansion will be there, and water intoxication, headache, confusion, seizures, etc. Coma, these will be the features. So that is what is about the ADH. Now the next hormone is the oxytocin. How, where does it act? It will act on the uterus. It acts as a estrogen, acts on the estrogen primed uterus. It stimulates the labor, and synthetic, it is available as a pitocin. So in the breast, the suckling by the baby will initiate the neurogenic reflex, and there will be oxytocin released. And these oxytocin will act on the myoepithelial cells, and there it will cause the contraction of these cells, and it will lead to the milk ejection. Okay. Now, apart from this oxytocin and vasopressin, we have hypothalamic releasing hormones. Okay, and what is the nature of these hormones? These are the peptides. Okay, they will act via portal circulation, like what we have seen oxytocin and ADH. They were the neuropeptides. Here, these are the peptides. They will act via the portal circulation. So they will go via the portal circulation to the pituitary. Okay, so there are two types of hypothalamic releasing hormones. They may be stimulatory, that is releasing hormones, and second is inhibitory. Okay, so they will act on the pituitary, will cause release of the hormones, or they may cause the inhibition of the release of hormones. Okay, the control mechanism is we have discussed. It is short loop, that the levels of these hormones from the pituitary will act at the level of the hypothalamus, while long loop, these are the target gland hormones, will control the levels at the level of the pituitary as well as hypothalamus. That is the long loop. We have discussed this. Now coming to the anterior pituitary hormones. Okay. Please remember, there can be question on this. So in anterior pituitary, it is the growth hormone. Then we have ACTH, TSH, FSH, LH, and prolactin. So 6 hormones are there: GH, ACTH, TSH, FSH, LH, and prolactin. So just concentrate here. FSH, LH, and TSH, put it in one group. Okay, FSH, LH, TSH, these are glycoprotein in nature. Okay, FSH, LH, TSH, these are glycoprotein in nature, while rest of the hormones, that is GH, ACTH, and prolactin, these are polypeptide in nature. So if you are asked about the nature of the hormones, so FSH, LH, and TSH, they are glycoprotein, while the rest GH, ACTH, prolactin, these are polypeptide in nature. Okay. Now, what is the key feature? Growth hormone will cause the growth and metabolism. Then ACTH is responsible for adrenal stimulation. TSH will cause thyroid stimulation. FSH is responsible for gametogenesis. LH is for steroidogenesis, and prolactin for lactation. Okay, so this is very simple. In certain exams, they have asked even the number of amino acids also. Okay, hormone and the how many amino acids are there. Okay, but it's not that difficult to remember. So we have seen 6 hormones: GH, ACTH, LH, FSH, TSH, and prolactin. So these 6 basically we are concerned with, out of which just group these 3 together. Okay, we have mentioned LH, FSH, and TSH. They are glycoprotein, and all of them will have 204. Okay, amino acids. They will have alpha unit and beta unit, and the alpha unit is common to all, 89, 89, 89. Okay, so FSH, LH, TSH, they all have approximately 204. Here it will be one less because beta unit has got 114 amino acids, while here it has got a 115. So 115 and 89. Okay, it is 204. Okay, so LH has got alpha unit of 89, beta unit of 115. Same for FSH also. TSH is 89 and 115. Okay. Then other hormones, then three are remaining: GH, ACTH, and prolactin. Prolactin is around 198. Okay, so again nearing around 200. Okay, this was 204. This is 198, and the remaining is 191. Growth hormone is 191, and the list is ACTH, that is 39. So longest this ACTH four alphabets here, but the list number is a 39. Okay. So just remember, anyhow, prolactin has got 198. Rarely this can be asked, not a very common, but I just wanted to make it more simplified for you. Okay. Now let's see each hormone one by one. So first is a growth hormone, also called as somatotropin. Okay. So basically, it is released from the somatotrophs, that these are the acidophil cells. Okay, this is a recall question, frequently asked question. Okay, so this growth hormone is secreted by, sometimes they can give acidophil also. Okay, so these are the somatotrophs or the acidophils which will secrete the growth hormone. Amino acid is 191 amino acid. Secretion pattern, remember, it is the deep sleep. Okay, this is secreted in the deep sleep. You get the peak levels. It is secreted in pulsatile manner, and it is increased after meals. Generally, after around 3 hours, it is increased. Okay, so, but deep sleep, you remember, growth hormone is released in the deep sleep. Okay, so how it is regulated? It is regulated by growth hormone releasing hormone. Then somatostatin, that is the growth hormone inhibiting hormone. So GHRH, growth hormone releasing hormone, from the hypothalamus, will increase the growth hormone secretion, while somatostatin, that is GHIH, it is an inhibitory hormone, will reduce the GH level, growth hormone level. Hypoglycemia increases the growth hormone level. Hyperglycemia will reduce the growth hormone level, and ghrelin will increase the growth hormone. Okay, so this is how it is regulated. Coming to the actions of the growth hormone, it will act via IGF-1, that is somatomedin. It increases the protein synthesis, that is, it is anabolic. It will also cause lipolysis. At blood glucose, it will increase the blood glucose level. It has got anti-insulin effect and increase bone and cartilage growth. Okay, so it is anabolic in nature. It will cause lipolysis, and it will increase the blood sugar level like other cortisol and all. So it has got an anti-insulin effect and increase bone and cartilage growth. Okay. Now, what are the clinical conditions related to this growth hormone? Excess of growth hormone in the child will be manifested as a gigantism, while excess in the adults will be manifested as acromegaly. Deficiency will lead to the pituitary dwarfism. Okay. Now, what is the test which is related to the growth hormone? You have L-DOPA stimulation test. Okay. Normally, what happens when you give L-DOPA, the in normal condition, growth hormone level will increase. But if the growth hormone is deficient, upon this giving the L-DOPA, there is no rise in the growth hormone level. Okay. So this L-DOPA stimulation test will be negative if the growth hormone is absent. Now coming to the next hormone, that is adrenocorticotropic hormone. Okay, so basically it is derived from POMC, that is pro-opiomelanocortin. Okay, so POMC, pro-opiomelanocortin, and this has got a 39 amino acids. We have seen ACTH, long alphabets, least number of amino acids, that is 39. It is secreted in a diurnal rhythm, and here the peak is in early morning. Lowest is seen in the midnight, while with the growth hormone, peak was in the night. Okay, here a deep sleep, the peak, there was a deep sleep. Here peak is in early morning. Lowest levels are seen in the midnight. Okay, with respect to the ACTH, early morning you get the peak levels. So it will act via cyclic AMP. It will stimulate the adrenal steroidogenesis, and the receptor responsible is a melanocortin 2 receptor. Okay. Clinically, if there is excess of this ACTH, it will lead to Cushing's disease, and deficiency will lead to the pan-hypopituitary deficiency, generally seen with a panhypopituitarism. Okay, so this is what about the ACTH. Okay, and this there are two terminologies. One is a Cushing disease and other is a Cushing syndrome. When Cushing syndrome is a broad terminology, when there is an excess of this ACTH for any reason, then it from any source, then we call it as a Cushing syndrome. But if it is due to pituitary adenoma, then we call it as a Cushing's disease. So Cushing's disease, when we say, it is related to the pituitary adenoma. While if the source is from anywhere, not related to the pituitary, then broadly it is called as a Cushing syndrome. Okay. So what are the tests which are related to this hormone? So we have co-syntropin test. This co-syntropin test will decrease the cortisol and will denote the adrenal insufficiency. Another test is a dexamethasone suppression test. There is no suppression in the Cushing's syndrome. Okay, so this dexamethasone suppression test sometimes is expected from the candidates. So this dexamethasone suppression test, there is no suppression when you give dexamethasone in Cushing's. Okay, so these two tests, co-syntropin test and the dexamethasone suppression test. In co-syntropin test, there is a primary failure, so adrenal cannot respond, and there is no rise cortisol rise. Okay, so there is adrenal insufficiency, there is a primary failure, and the adrenal cannot respond, so there is no cortisol rise when you give co-syntropin. Okay, now in dexamethasone suppression test, there is no suppression in the Cushing's syndrome. Okay, so when there is a Cushing's, there is, and you give dexamethasone, there is no suppression of the cortisol. Okay, so dexamethasone should suppress the cortisol via negative feedback, and failure to suppress indicates the Cushing syndrome. So when you give dexamethasone, it should suppress the cortisol level normally. However, there is no suppression when it is a Cushing syndrome. Okay, basically there are two types of tests. Sometimes if they ask you in detail in options, you may have low dose dexa suppression test and the high dose suppression test. So we may get confused. So that is why I have mentioned here. Basically, low dose dexamethasone test is a screening test. It will just detect the Cushing syndrome. It will not find out the cause. So purpose of the low dose dexa test is to detect whether it is a Cushing syndrome or not. So when you give low dose dexa, in that case, there will be no suppression of the cortisol. So normally what happens, the cortisol level will decrease. But in Cushing syndrome, there is no suppression of the cortisol. So no suppression, there is a Cushing syndrome. Okay, and this is with the low dose. Now, once we have diagnosed that it is a Cushing syndrome, then we should diagnose what is the cause. So the purpose of the high dose is to find out the cause of Cushing syndrome. Okay, so when it is a Cushing disease, that is the pituitary edema, then there will be partial suppression. So if it is a Cushing disease, then it is a partial suppression. While if it is ectopic ACTH or adrenal tumor, then there is no suppression of the cortisol level. Okay, only pituitary shows suppression. So high dose test is mainly to look for this pituitary suppression. That is why if it is a pituitary adenoma, then there will be partial suppression. So only pituitary will show suppression, while ectopic ACTH and adrenal, they will not show any suppression. Okay, so just in short, low dose is for the diagnosis, high dose is for the differentiation. Okay, so now we go for the next hormones. These are the glycoprotein hormones, that is TSH, FSH, and LH. Okay, so previously we have seen polypeptides. Now we will see about the glycoprotein hormones, TSH, FSH, and LH. Basically, we have discussed they have got two subunits, alpha subunit and the beta subunit. Alpha subunit will be common to all three, while beta subunit will be very specific to that particular hormone. Okay, alpha subunit is also common with the SCG. Okay, this also we know that alpha subunit of TSH, FSH, LH is common with the SCG. Okay, now let's talk about the TSH. Okay, what is the action of TSH? It stimulates the thyroxine synthesis. It acts via cyclic AMP mediated action is seen. Okay, now how it is regulated. So TRH, which is coming from the hypothalamus, it will increase the TSH level. Then the thyroid hormone will decrease the TSH level, and prolactin inhibitory factor, which is nothing but the dopamine, will also decrease the TSH. Okay, so if you have got a prolactin inhibiting hormone or dopamine that will reduce the TSH. Now, clinical effect, when you get increased TSH, that will lead to the primary hypothyroidism, then Hashimoto's thyroiditis and TSH secreting tumors. Okay. Then decreased TSH, you will see in the hyperthyroidism, pituitary and hypothalamic failure. Okay. So these are the sometimes they can ask you in the data interpretation. We will have few questions on the data interpretation if possible today itself. Okay, so increased TSH level will be seen in primary hypothyroidism, Hashimoto's thyroiditis, and TSH secreting tumors, while decreased TSH levels are seen in hyperthyroidism, pituitary, and hypothalamic failure. Okay, now next is a gonadotropins, FSH and LH. Okay, and here the what were the number of amino acids we discussed, alpha subunit and the beta subunit. Okay, total around it was around coming to 204. Okay, one was 85 and other was, what was the hormone, this alpha and beta subunit? Yes, 115 and 89. Okay, so these numbers also you should remember. Okay. So gonadotropins, it is stimulated by the GnRH and requires pulsatile secretion. FSH causes follicular growth and spermatogenesis, while LH leads to the ovulation and steroidogenesis. In menstrual cycle, in the follicular phase, you have the higher levels of FSH. Then there is a LH surge that leads to the ovulation, and post-ovulation, again the FSH and LH levels will be reduced. Post-ovulation, there will be decreased FSH and LH levels. Okay. Now, what is the feedback mechanism? The sex hormones level will give the negative feedback. In menopause, there is an increase in the FSH and LH levels. Okay. Now, clinical interpretation of the FSH and LH. Okay, these are also the questions which are asked. They will give you the values and they'll ask you the in which case or what will be the diagnosis. Okay, so increased FSH level is seen in gonadal failure, menopause, Klinefelter, while decreased FSH levels are seen in pituitary, hypothalamic disease, PCOS, pregnancy, etc. Then coming to the LH, LH levels are increased in PCOS and menopause, while LH levels are decreased in hypothalamic dysfunction and the Kallmann syndrome. Okay. Now, what are the abnormalities of the gonadotropin? Okay, if there are abnormalities of the gonadotropin, how it will manifest? Suppose if it is a prepubertal deficiency in the male, then there will be failure to attain the puberty. No secondary sexual characteristics will be developed in male. If it is a post-pubertal deficiency in male, then it will present as an infertility, loss of libido, impotence, testicular failure. And if there is excessive secretion, it will cause precocious puberty both in male as well as females. Okay, so precocious puberty is mainly because of the excessive gonadotropins, okay, both in male and female. While in females, if there is a prepubertal deficiency, that will lead to the failure to attain the menarche. Okay, patient may present as a primary amenorrhea. And if it is post-pubertal deficiency, it will lead to the infertility, amenorrhea, ovarian failure, etc. So from examination point of view, low FSH and low LH levels, it is the central cause we'll think about. If FSH and LH levels are high, we will think about the gonadal failure. Okay. Now let's go to the next hormone, that is a prolactin. This prolactin is controlled by the dopamine, which is the inhibiting factor, also called as prolactin inhibiting factor. It's the dopamine. Okay. Then it is stimulated by the TRH levels and the VRP levels. Okay. So what is the function? Function is the initiation and maintenance of lactation, increase milk protein and fat synthesis. It is secreted in the REM sleep between 4 to 6 a.m. Clinically, hyperprolactinemia may lead to the infertility, and the tests related to the prolactin are chlorpromazine test, which will increase the prolactin level, and L-DOPA suppression. There is no suppression in prolactin. Okay, so if it is a prolactinoma with L-DOPA, there is no suppression, that will reflect the prolactinoma. Okay, so from the examination point of view, certain things we should remember. ADH is regulated by the plasma osmolality. Okay, so ADH level is mainly controlled by the plasma osmolality. In SIADH, there is a hyponatremia plus low osmolality. Then GH peak, growth hormone peak is seen in the deep sleep. While ACTH, there is a diurnal rhythm, there is a morning peak. LH surge, there is a ovulation, that is a ovulation trigger. Dopamine is the main inhibitor of prolactin. Alpha supernatant is common for TSH, FSH, LH, SCG. Then GnRH must be pulsatile. That is, if it is secreted continuously, then there is a suppression. Okay. So that finishes the anterior pituitary hormones. We have few questions, doctor. Can you please go through these questions?
Yes, ma'am. A 45-year-old woman present with confusion and urine is inappropriately concentrated. What is the most likely diagnosis? Option A, diabetes insipidus. Option B, SARDH. Option C, hyperaldosteronism. Option D, hypothyroidism. Option E, Addison's disease. So answer is uh, option B, SIADH.
Because there is a hyponatremia and low plasma osmolality. Okay, so the answer is SIADH. Okay, SIADH causes excess ADH secretion, so that is will lead to the water retention that will cause a dilutional hyponatremia plus low osmolality with inappropriately concentrated urine. There will be neurological symptoms due to the cerebral edema. Next question, doctor.
Which of the following is the primary regulator of ADH secretion? Option A, blood pressure. Option B, plasma sodium. Option C, plasma osmolarity. Option D, potassium levels. Option E, renin levels. The answer is C, plasma osmolarity.
Correct. It is the plasma osmolarity which controls this ADH. So ADH secretion is mainly regulated by plasma osmolarity. Increased plasma osmolarity will lead to increased ADH, and decreased osmolarity will lead to the decreased ADH. Next.
A patient passes large volume of diluted urine with hypernatremia. What is the most likely underlying defect? Option A, excess ADH secretion. Option B, ADH deficiency. Option C, increased aldosterone. Option D, increased renin. Option E, increased ANP. The answer is ADH deficiency.
Yes, that is a typical picture of diabetes insipidus. Okay. So ADH deficiency will lead to the diabetes insipidus, inability to concentrate urine, leading to polyuria with hypernatremia. Okay. Next.
Oxytocin primarily affects through which mechanism in the breast? Option A, stimulate milk production. Option B, inhibit prolactin. Option C, contract myoepithelial cells. Option D, increase fat synthesis. Option E, enhance ductal growth. Sir, option C, contract myoepithelial cells.
Absolutely correct. So this oxytocin will act on this myoepithelial cells. Oxytocin causes milk ejection, let down reflex by contracting myoepithelial cells. Prolactin is responsible for milk production. Okay. Next.
Which hypothalamic hormone inhibit growth hormone secretion? Option A, GHRH. Option B, TRH. Option C, somatostatin. Option D, GnRH. Option E, CRH. The answer is option C, somatostatin.
Yes, that is the inhibiting hormone for the growth hormone. Okay, somatostatin. Somatostatin is a GHIH is the main inhibitory regulator for growth hormone secretion. Next.
A child with excessive linear growth is diagnosed with a pituitary tumor. Which hormone is most likely elevated? Option A, ACTH. Option B, GH. Option C, TSH. Option D, LH. Option E, prolactin. The answer is option B, GH.
Yes, there is a linear growth increase that is mainly because of the growth hormone. Excess growth hormone before epiphyseal closure will lead to the gigantism. Next.
Which of the following stimulate growth hormone secretion? Option A, hyperglycemia. Option B, somatostatin. Option C, hypoglycemia. Option D, IGF-1. Option E, cortisol. Sir, option C, hypoglycemia.
Hypoglycemia. Okay, so it is the hypoglycemia stimulates growth hormone while hyperglycemia will suppress it. Next.
Growth hormone exert many of its peripheral effect via A, insulin, B, cortisol, C, IGF-1, D. Thyroxine, E. Glucagon. So option C, IGF-1.
Yes, it will act through the IGF-1. GH acts indirectly via somatomedin, that is IGF-1, to promote the growth. Now coming to the ACTH hormone. Okay.
ACTH is derived from which precursor molecule? A. Preproinsulin, B. POMC, C. Prolactin, D. Thyroglobulin, E. Angiotensinogen. The answer is B. POMC.
Yes. Pro-opiomelanocortin. Okay, so POMC is the answer. ACTH is cleaved from pro-opiomelanocortin, POMC. Next.
Which hormone shows marked A. GH, B. ACTH, C. Prolactin, D. FSH, E. LH. The answer is B. ACTH.
Which shows a marked diurnal variation with peak secretion in the early morning. Yes, ACTH is the so ACTH secretion peaks in the early morning, paralleling the cortisol rhythm. Next.
A failure of cortisol suppression after dexamethasone administration suggests A. Hypopituitarism, B. Addison's disease, C. Cushing syndrome, D. Hypothyroidism, E. SIADH. Sir, option B. So option C, Cushing disease.
Yes,
Cushing
Cushing.
syndrome.
Don't get confused between Addison's and Cushing's. Okay, so it is a Cushing syndrome. DEXA suppression test, a Cushing syndrome. Okay, that also we have seen. There is a low dose and a high dose. Low dose is a screening test to consider to see it is a Cushing syndrome. Then high dose is for differentiating. Okay, so in Cushing syndrome, negative feedback fails, so cortisol is not suppressed. Next.
Which pituitary hormone share common alpha subunit? A. GH and ACTH, B. ACTH and PRL, C. TSH, FSH, LH, D. GH, PRL, E. ACTH, TSH. Sir, answer is C. TSH,
Yeah.
FSH,
So
LH.
they have common alpha unit, alpha subunit. The hormone level, how many units? I think 84, 85. These glycoproteins share a common alpha subunit but have distinct beta subunit. Okay? Or it is 204 total, I guess it is. Okay, go ahead.
Which hormone is primarily responsible for triggering ovulation? A. FSH, B. LH, C. Estrogen, D. Progesterone, and E. Prolactin. Sir, answer is B. LH.
Yes, primary responsible triggering ovulation, the LS surge is there. Okay, so the LS surge induces ovulation. Next.
A postmenopausal woman is expected to have each of the following hormone profile. A. Low FSH, low LH. B. High FSH, high LH. C. Low FSH, high LH. D. High FSH, low LH. E. Normal FSH, high LH. The answer is B. High FSH, high LH.
Okay, yeah. So high FSH, high LH, loss of estrogen will lead to loss of negative feedback, increase FSH and LH. Next.
A low FSH LH level in patient with hypogonadism suggests A. Primary gonadal failure, B. Hypothalamic or pituitary disorder, C. Menopause, D. PCOS, E. Klinefelter syndrome.
FSH, LH levels are low. That means where is the fault?
The central defect,
Yeah,
so it
so
is hypothalamic or
hypothalamic or pituitary disorder. Okay, that is the central cause. Next.
which hormone is primarily inhibited by dopamine? A. GH, B. ACTH, C. Prolactin, D. TSH, E. LH. The answer is prolactin.
Correct. Prolactin inhibitory hormone is the dopamine. Next.
A woman present with infertility and galactorrhea, which is the most likely hormone abnormality? A. Low prolactin, B. High prolactin, C. High LH, D. Low TSH, E. High GH. Sir, high prolactin.
Correct.
B option.
Hyperprolactin. Hyperprolactinemia lead to infertility and galactorrhea. Next.
Which hypothalamic hormone stimulate both TSH and prolactin secretion? A. GnRH, C. CRH, uh, A. GnRH, B. CRH, C. TRH, D. Somatostatin, E. Dopamine. Sir, answer is C, TRH.
Yeah. So releasing factor is TRH. Okay. So TRH stimulates both TSH and prolactin release. Next.
A continuous, that is non-pulsatile GnRH administration result in increased LH and FSH, suppression of LH and FSH, increased prolactin, increased GH, and increased ACTH. Sir, option B, suppression of LH
Yeah.
and FSH.
If it is a non-pulsatile, then it will lead to the suppression of LSH and FSH and LH. So GnRH must be pulsatile. Continuous exposure will lead to down regulation, leading to suppression. I think last. Next.
A patient has elevated TSH with low T3
Patient has elevated TSH with low T3, T4 levels. What is the most likely diagnosis?
uh, option A, secondary hypothyroidism. Option B, primary hypothyroidism. Option C, hyperthyroidism. Option D, euthyroid 6 syndrome. Option E, pituitary adenoma. Sir, so it is a primary hypothyroidism.
Yes, T3, T4 levels are low, TSH is increased, so it is a primary hypothyroidism. Low thyroid hormones, there is a loss of feedback, increased TSH levels, and primary hypothyroid, primary thyroid failure is that. Okay, so that finishes today's topic. Thank you.